Pennsylvania Prevention and Research Advisory Board, as well as the Pennsylvania Cancer Coalition. So I welcome you to today's sessions. Kate, next slide, please. Just what we'll be covering today. I think it's incredibly important that we continue to look at cancer prevention trends. We talk a little bit about our survivorship demonstration project, looking at cancer control funding in the future. We will take a quick break because 3 hours is an awful lot to be online. Cancer care during the pandemic, which was a topic that was brought up to us by one of the clinicians in the area that wanted some initial information on best practice methodologies. We have an expert panel to be able to review what multiple institutions across the state have done during the pandemic. And then, of course, we have some closing Q&A and remarks. Next slide, please. So welcoming you to the advisory board. Please note that all questions are welcome during the session, and we want to make sure that you have the ability to use the chat line in the event that you don't want to disturb during presentation. Next slide, please. So this is our conflict of interest, adverse interest documentation. Of course, you can read it, but basically it's telling you that we are working to make sure that we have no conflict of interest or any other adverse interest regarding the opportunity to look at RFPs and grants contracts. Next slide, please. Please note, the meeting is currently being recorded. It actually kicked in as I was speaking, and that you will be able to gather additional information by going to the pacancercoalition.org for any future reference, or if you wish to share with any members of your team post this session. Next slide, please. CDC announcements. We want to make sure that people are aware of CDC funding for the year, beginning in June. So with that, the Comprehensive Cancer Control Program has received funding. Survivorship Supplement has received. There's a Breast and Cervical Early Detection Program, and of course the Pennsylvania Cancer Registry, which does such a great job with all of our data management. We wanted to welcome Brenda Anastasio and Wendy Aldinger to help us on the Data Advisory Committee. So Brenda and Wendy, of course, working in comprehensive cancer control and the Pennsylvania Cancer Registry are essential elements to how we look at the state for fairness and equity of services. Next slide, please. We wanted to welcome Kelly Holland, who's the Director of the Bureau for Health Promotion and Risk Reduction, will be a Governor's Advisory Board, Cancer Advisory Board member under the Secretary of Health proxy. Next slide, please. We also want to go into a little bit of detail and information for cancer effects among Pennsylvanians. So I welcome Nathan Worth to be able to go through some content and information regarding the statistics for the state.
Nathan, if you'd prefer, I can advance your slides too.
Yep, that'd be good.
Okay, great.
All right. So the Data Advisory Committee, to help the CAB plan for the coming year, collects data to outline cancer's effect on public health in Pennsylvania. Today, we're going to look at projections for incidence and death that we have for this year, how they compare to past numbers, which counties are seeing poor trends, rates of early diagnosis, socioeconomic correlations, and we'll finish up with a very brief look at how COVID pandemic is going to impact data collection and all of this. So with only 20 minutes, I'm going to be moving pretty fast. Like they said, they're going to save the slides. It'll be available afterwards. I might skip a few, but feel free to come back and look at them again. Next slide. So the projected 2020 diagnoses by sex. Cancer cases and deaths are delayed for various reasons. So we project for this year to know what we're going to be dealing with now. It lets people plan for more current events. In 2020, we expect breast, prostate, lung, and colorectal cancers to remain the most common cancer diagnoses. And except for breast and thyroid cancer, more men will be diagnosed for each non-sex-specific type of cancer. Next slide. In 2020, we also expect lung, breast, prostate, and colorectal cancers to remain the most common cancer death. Again, except for breast and thyroid cancers, more men will die of each non-sex-specific type of cancer. Next slide. So we compared these 2020 projections to the counts that we saw 5 years ago in 2015. And we see liver cancer is expected to have the largest relative increase. Considering this cancer type has a 5-year net survival rate of 17.1%, this is a very worrying trend. However, the prostate and colorectal cancers, which were the third and fourth leading causes of cancer death, are expected to be less commonly diagnosed than 5 years. Next slide. Comparing the projected cancer deaths for this year to those from 2015, again, liver is expected to rise. Prostate cancer is expected to see a small relative increase in death, despite having been projected to decrease in diagnosis counts. Conversely, breast cancer is expected to cause fewer deaths, despite the projections showing more diagnoses. And a possible explanation could be the trend in the number of early diagnoses, which are much easier to treat and have much better prognosis. And we'll look at this again in a few minutes. Next slide. So comparing the projected diagnoses again, 2020, 2015, we expect large relative increases in northeastern counties and Lancaster in the south. And this is for all cancers combined. The number of diagnoses in Allegheny is expected to decrease a little bit. And the same is true for Philadelphia and its surrounding counties, except for Bucks, which has a small increase. Now, keep in mind, estimates are less reliable for the low population counties. So a lot of those in the north and around the central region, except for Center County. Next slide, please. For projected cancer deaths in 2020, comparing those to 2015, the numbers again expected to decrease in Allegheny and Philadelphia. Half of Philly's neighboring counties are expected to see slightly more cancer deaths. Of the counties with an expected large increase in cancer deaths, Fayette, Lycoming, and Northumberland are the largest by population. Next slide. As mentioned before, one of the biggest factors in outcomes is the stage when a cancer is discovered. There's a wide spread of early diagnosis rates between the cancers that are focused on in the cancer plan, and those are shown here. The unstaged section in the middle includes cases when a physician could not determine what stage the cancer was at, or when the tumor is found after death. In 2017, a larger percentage of liver cancers were discovered after death than for any other major cancer site. Cancers that are routinely screened for, such as melanoma and breast, have relatively high rates of early diagnosis. While a CAT or CT scan is now recommended for lung cancer screening in some patients, the majority of lung cancer diagnoses in 2017 were at a late stage. However, this is still an improvement from the past. Next slide. Since 2013, when the United States Preventative Service Task Force recommended lung cancer screening for some patients, the rate of early diagnosed lung cancers has risen sharply. For breast cancer, the rising percentage of early stage cases would explain the predicted increase in deaths. Other way. Would explain the predicted decrease in deaths despite increase in diagnosis. All right, next slide. The percentage of early stage prostate cancer diagnoses has fallen over the years. While the change recommendation on PSA screening in 2012 may have played a part, the downward trend has existed for over a decade. Colorectal cancer saw a similar downward trend. This meaning is harder to judge because cancer registries don't collect reports on polyp that might have turned into colorectal cancer. If they're removed during a colorectal cancer screening, those have possibly prevented cancers, but they'll never show up in our data. Next slide. So the registry doesn't collect patients' income levels, but it does collect address, and we can match those to census tracts and figure out poverty levels for the neighborhoods around these patients. And we follow a national standard for defining neighborhood poverty. We group by percentage of households below the federal poverty line. Here we can see how many Pennsylvanians were in each group for the period of 2013-2017. This shows that no group is negligible in size. So all the following statistics are worth looking at. Next slide. We looked at age-adjusted incidence rates by neighborhood poverty levels. Because race is highly correlated with socioeconomic status, we keep that in mind when looking at poverty data. These first four types of cancer didn't show pronounced difference, so comparisons by poverty are easier to interpret. All of these have 95% confidence intervals, though many are too small to see. Unsurprisingly, higher poverty levels correlate with higher incidence rates usually, except for breast cancer among women, and their low poverty neighborhoods actually had a higher incidence rate. Next slide. These four cancers did have a large difference between races. So comparing by poverty, that's a little bit muddled. Still, we can see something. Prostate cancer has an odd pattern where it has higher rates at both ends of the poverty spectrum. For the other three types, it's still better to look at them by race. Next slide. To compare incidence trends by race, we'll use the model data available from the cancer dashboard. The dashed lines show the observed trends, and the solid lines show the smooth trend segments. Those are just easier to compare. So colorectal and lung cancer rates have fallen for all races shown. The rate of liver cancer increased for all races, but the trend has been much steeper among Black Pennsylvanians. Next slide. Recently, breast cancer incidence rates have been trending upward. Melanoma has been increasing for a while. The dip in 2016 wasn't enough to say the trend is over yet. Cervical cancer rates have been falling. Same with prostate cancer, except for the very recent uptick among white Pennsylvanians. We'll see if that continued when the models are updated with 2017 data, which should be on the cancer dashboard soon. Next slide. We wanted to specifically call out colorectal cancer trends here because they're a little bit worried. While overall the rate is falling, it is rising among all age groups under 50, which is the age when colorectal screening is first recommended. So younger Pennsylvanians still have a much lower incidence rate. In 2017, the rate was 28.1 per 100,000 for the 40 to 49 age group, and 119.5 for the 50 and older. However, you can see that the younger the age group, the sharper the trend upwards. Next slide. The COVID-19 pandemic has greatly affected all corners of the healthcare system, including cancer data. IQVIA, which is a health informatics and research company, estimated that 22 million cancer screenings have not been done in the United States because of COVID-19. This was based on claims data they had up to April 10th, which showed a 70 to 80% decline in physician visit compared to February. They did find that oncologists would favor more dire prognosis cancers. So they were seeing less skin cancer patients, but patients with pancreatic cancer, for example, had about the same level of patient visitation. So everything's down overall, but they're trying to make sure that no one is left out in the rain and in a bad situation. Next slide. So 22 million cancer screenings across the U.S. is what they estimated. However, more recent analyses indicate that that dip in visitations might not be as bad. So Phreesia is a company that provides intake and payment software to healthcare businesses. And using their data, they saw there was a rebound in physician visits after the beginning of April. The number of visits for their customers went from 40% of normal to 70% by mid-May. Of course, I have to finish with all of these numbers are just best effort estimates. Data sources and reporting systems are also affected by pandemic response. And that includes the Cancer Registry. And we're sure to see new retrospectives as they come in the coming months and people figure out how all of this has affected our data. So as mentioned before, if there are any questions, please write them in the chat window, or you can always email me about this or any other data item that you want to discuss at any time. My email is nworth@. Thanks for your time, and I hope everyone is staying healthy.
Thank you, Nathan. There was a chat, a question that came in the chat from Suzanne asking if you said that the oral cavity cancer increase is likely the result of HPV.
No, I did not mention that, and I have not looked at data that would show either way with that.
Thank you. And so as Nathan mentioned, if there's questions that do continue to come to mind, please utilize the chat. And we'll continue to answer those questions either live or throughout.
Hello, Peg, this is Pat. I have something on the cancer statistics for, I don't know if you can hear me. Can you hear me?
Yeah, Pat, we can hear you. Please go right ahead.
Okay. On the breast cancer screening and the attribution of a decrease in deaths due to earlier diagnosis, we have some good news to report on that. And that is that Senate Bill 595, which would require for the first time that insurers cover the cost of MRIs and ultrasounds for women with very dense breasts and other high-risk conditions, passed the Senate unanimously and is now in the House, was reported out of the House Insurance Committee unanimously 2 weeks ago. It was supposed to move on the floor of the House this week, but they got involved in other business. So we are hopeful that it will pass the House before it goes out of session for the summer. And we're very encouraged about this. The insurers agreed to remain neutral on the bill, and that's a plus. And it would mean that women with very dense breasts and homogeneously dense breasts would have the opportunity to get their MRIs and or ultrasounds covered by their insurer. And this is the next step in breast cancer screening. Some of you may be familiar with the recent article in JAMA, Journal of the American Medical Association, that showed in a clinical trial, very large clinical trial, that MRIs are 2.5 times more effective than even 3D mammograms in detecting breast cancer in that group of high risk, extremely dense breast women. So it really is the next step in early detection for a very large group of women. We're hopeful that the governor will sign the bill, although we don't have an inclination from him yet, which one way or the other. And some of you are familiar with this. I know, is Aurelia on the call? If she is, she and I have had an opportunity to talk about this. But it's almost as important as getting, maybe more important than getting 3D mammograms covered for free, which the governor did 4 years ago and made Pennsylvania the first state in the nation. to have free 3D mammograms, and we think that was instrumental in saving a number of lives. And we see this as the next step. So it will be interesting when that is passed and in practice, what will happen with the early detection and the early diagnosis of breast cancer. And I don't know, Aurelia, I know you've looked into this and you might have something you might want to say.
Pat, if Aurelia's not quite prepared yet,
Okay.
there was a question.
Thank you, Pat.
I'm sorry. This is Peg. Evelyn Gonzalez wanted to know, do you know if MRI will be added to the Healthy Women program, Pat, for coverage?
I don't know that yet. What I'm thinking is a one step at a time. 3D mammograms were, once the governor included them as one of the items under current law. So we're optimistic, hopeful about that. But Evelyn, I don't have an answer to that. The bill isn't passed yet and the governor hasn't signed it yet. So right now, we don't see any particular, it wouldn't be required. And since it isn't required in the legislation, it means that the bill won't need a fiscal note. And for those of you who do legislation, I think you understand how important it is for it not to have a fiscal note at this particular time. And then after that, of course, the state may very well be interested in extending MRIs to the Healthy Women program. And somebody else wants to speak to that.
Casey Monroe from Adagio Health. I just wanted to jump in there, Pat. This is Casey Monroe from Adagio Health. The breast and cervical cancer early detection program, formerly known as the Healthy Woman, does cover MRIs. So those are covered through the program.
Thank you. And I appreciate that. I was aware of that, but I didn't know whether, how can I put it was required or whether it's funded. And I don't know that I want to know the answer at the moment, whether it's funded under CDC money or state money. For instance, we got legislation through.
Pat?
Yes.
Could you hold on one moment? I'm going to mute everybody again just to lessen some of that background noise, and then you can continue to speak if you just want to give me one moment.
Sure. I was aware that women could get MRIs. What I don't know is whether or not it's funded. And as I say, I don't think I want to know the answer at the moment, whether it's funded under the CDC appropriation, which is federal money, or whether it's under the money that we got appropriated, in the Rendell administration to expand Healthy Women coverage to women 40 to 49. And if it's under CDC, that's very helpful. Maybe I shouldn't say this. If it's under Healthy Women, I don't want to know about it right now.
Thank you for that update. That's an important update to share to this group. If any questions that come up or even other updates, if you can utilize the chat, we'll make sure to circle back to.
Yeah, this is Oralia Dominic. I was didn't know how to unmute myself, so sorry about that. It's a delayed response to Pat, and thank you, Pat, for the update. I just wanted to communicate that Pat and I have been in discussion. She has made me aware of this new technology that seems to be having promising results, and I will continue to work closely with her to learn more about this so that we can have new discovery translate for public and clinic use.
Thank you, Aurelia.
Maybe an appropriate time for the CAB, if it wishes to do so, either individually or as a group, to ask the governor to sign this legislation when it gets to his desk. That always helps. And perhaps we could ask Secretary Levine if she could help support it as well, because I think it will make as big a difference as 3D mammograms have, maybe even a bigger difference.
Great points. Calls to action are always important. Thank you. Before we move to the next section of the agenda, just to circle back, I don't know if Kelly Holland, who was announced earlier, if she is on and could come up of mute, and maybe if you wanted to say a few words about just about your new role. If I don't know if you're on mute, you would have to remove yourself from mute. If not, we could always come back at a later point. Okay. All right, so we're going to move then to the next space of our agenda, which is a discussion on our survivorship demonstration project. So the team that worked on this together includes Christina Reardon, who's a research associate from Temple University, Mark Witovich, administrative director of Geisinger Cancer Institute, and Maggie Arneson, special projects manager for our comprehensive cancer program. So they're going to take us through this project. So if you guys want to come off of mute, I'll advance your slides and I'll turn it over to you to kick off this section of our agenda. Thank you.
Hi, everyone. This is Maggie. So give me my next slide. That'd be great. So this is we're calling this a survivorship delivery model project. So I guess over a year ago, the Pennsylvania Cancer Control Program was made aware of increased funding from CDC as a special supplemental project with the goal of impacting quality of life of cancer survivors. And the way that this grant was structured was to run a brief survey and incorporate the few survivorship model questions provided by CDC. So when we were reviewing whether or not we wanted to apply for this grant, we were allowed to propose a different type of survey model because, within the program, we decided, after meeting with partners, speaking with other organizations, we decided if we were going to apply for this special funding, we wanted to really run a true data analysis project. We wanted to really dig into survivorship quality of life data in a real-time way instead of using BRIF's model questions, the behavioral risk assessment, because that includes surveys of people who may have had cancer 20 years ago, who just had a completely different experience. And again, it's survey data, so it's not as reliable. So you can see in the bullets below that those are the four main goals and objectives of this funding. And so we really focus on the primary objective, which is to monitor survivor needs, to try to figure out a good way to assess survivors' quality of life as they leave cancer treatment and as they become survivors in that 5-year window where we're really following them closely. So while we were planning our grant application for this, we did meet with different organizations. We worked closely with the American Cancer Society to kind of put together an application that we thought would meet the requirements of the funding, and also to create a project that would really provide concrete information to Pennsylvania. And so we did submit the application and we were successful, and we proposed to use a different survey system instead of running the BRIFS questions, which would have been very cost prohibitive and would have been on a non-annual cycle. So in our proposal, we ended up working with Geisinger Health System as well as Temple University. And so this project has kind of been split into two areas that I'm going to let Mark and Christina talk about in a little further detail, but basically we're focusing on data analysis using the EHR data and using the survey data that Geisinger is already collecting in its patient interactions with cancer survivors, and then an evaluation of care delivery, which is what Temple is really going to focus on. What does cancer survivorship care look like at different models at different sites across the Geisinger system? So like I said, we're focused very much on collecting survivorship data. We're looking at two different cohorts, one that received survivorship resources, ones that didn't. We're using a different survey model that has actual patient, clinical data tied to it. And we're going to be looking at clinical outcomes and trying to tie that to patients who have kind of gone through the survivorship care program at Geisinger. So one of the end goals and one of the end requirements of this funding is the creation of a white paper. So you can see that one of the goals of the grant, as listed above, are promoting resources, best practices, and guidelines. So our goal is that the findings and the information that we gather from this data analysis project will be rolled out to the entire state as kind of guidelines within the white paper, so that other health systems and other care centers will be able to review these findings and implement and change their own survivorship care practices as well. So that's kind of the Department of Health overview of how we came across this funding and how we started this 3-year project. And now I'm going to turn it over to Mark to talk about the Geisinger side.
Great, thanks, Maggie. Kate, can you advance to the next slide, please? And one more slide. Perfect. Well, thank you, everybody. Thanks to both the Department of Health and also Temple in their partnership and really kind of creating a framework around which we would kind of evaluate and assess the particular status and environment around survivorship care. I think it's particularly important right now that we continue to keep our patients that are transitioning off of active therapy, in mind and connected with us in a number of ways. So I think this project is going to be very helpful in how we do that over the next several months. So for those of you that are not as familiar with survivorship care, I know that there's folks on here as part of the CAB and also the PCC that are very intimately involved in the delivery of survivorship care. So I don't mean to oversimplify any aspects of this, but I'll just kind of touch on really the components of survivorship care, being that we really try to aim to touch on prevention of recurrent or new cancers. There's the surveillance component for continuing to monitor patients after they've completed their therapy, and also looking at the intervention and coordination of those interventions for patients that are still in need of services and support after completing their active therapy and kind of transitioning to a new normal and to other aspects of daily living. So those are kind of the components of survivorship care that we just kind of frame and keep in mind. And there's many different frameworks around survivorship care, and we always do at Geisinger. We think of really survivorship care beginning at that moment of diagnosis and kind of how we aim to care for the patient as a whole and all aspects and domains of their care. So this is just again another framework around survivorship care. Next slide, please. So really the aim in survivorship care that was outlined by the clinical group at Geisinger was really this aspirational kind of what does clinical excellence look like in survivorship care. So, at the time in 2017 and 2016, 2017, doing some program planning around how do we rise up to that, to meet those standards that folks have outlined in the literature and the research dictates, as well as standards that were outlined, by the American Cancer Society, by the Commission on Cancer, and others around those components of survivorship care. And really, what we've organized is, the ability to identify those patients across oncology care clinics. So obviously, with any intervention and conversation with patients, we want to be there, with the right patient at the right time. And these conversations should be kind of on a continuum where there's expectations around what a transition may look like for patients, and then what their needs are, both in kind of directly after therapy, and then as their needs may change over time, staying in tune to those things. So we really need to identify patients that are in need of survivorship care at the right time. And another program objective was really around assessing and managing late and long-term effects of cancer treatment. And it's very difficult to assess, to manage what you don't assess. And so we really wanted to have a standard approach on how we assess patient needs and kind of the standard in which we work from when having conversations with patients about creating a tailored, personalized plan for their survivorship. And obviously in any survivorship care program, there's that education component. So we really wanted to aim to be a resource for providers, clinicians, our nurses, and by extension, all of our staff and the employee community around what is survivorship care, who plays a part in that, and how can folks contribute to helping patients through different transitions in their care. And so we really became a group that was focused on how do we educate and how do we get the word out. And then obviously, being a coordinating center. So what are the makeup of a team that would have the capability and ability to coordinate within a health system and coordinate care for patients, getting them to where they need to go, and assisting patients with some of those logistics, and kind of, you can give a patient a plan, but how do you help them execute it? And then lastly, the group really wanted to make sure that continuous quality improvement in research in cancer survivorship was a ongoing component of our program, which made this a really great opportunity to partner with Temple on taking a step back and plan to look closely at our program. Next slide, please. So in October of 2018, we did implement a different degree of survivorship care model at Geisinger Medical Center in Danville. We implemented a multidisciplinary shared care model. So this was really led by an advanced practitioner in our oncology clinic. And it was really kind of held together by a new role for our system around a designated survivorship nurse navigator. So this was an RN licensed individual that was going to be a point person for helping us identify patients that are completing their treatment and coordinating an assessment with the patient, and then also assisting with implementing the plan for follow-up for the patient. In addition to that, we really recognized that we wanted to integrate our licensed social workers into the team, partner with our nutritionist group, and also we have a program on our campus around integrative medicine for patients. And we really wanted to incorporate that into our survivorship program, as well as just different options and different specialists that could be part of kind of a one-stop shop discussion with our patients. And of course, there's many other types of models and types of services that could be integrated into a kind of a multidisciplinary team. We kind of took the approach of, again, working with those services that we could get, that had capacity to kind of, commit the time and resources to establish the multidisciplinary environment, while really knowing the avenues for other referrals to services on how to assist patients in accessing those services. So really the model was around, can we bring some various specialists together in the same space to have a discussion with a patient and develop a personalized plan and make sure that they're having the best transition that they could after therapy. Next slide, please. So really to do this, we really took a personalized, look at how do we assess needs for cancer survivors and our patients that have completed their active treatment and are really kind of in position to receive a survivorship care plan. So how do we tailor that for an individual patient in kind of a systematic way? We assessed a number of different quality of life assessments, and one that a number of our researchers and also some of our clinicians were familiar with was using a functional assessment of cancer therapy, or the FACT GP assessment. And there's a number of different questionnaires and survey tools that could be used. And really, we aim to try to identify an assessment tool that was general in that it covered a number of domains for our patients, but also that there weren't too many questions, that it was burdensome, and that it really was part of a conversation to help identify areas where we might be able to better support patients. So really, the FACT GP is a assessment tool that we now that we use in routine clinical care delivery. The tool is now built within our Epic EMR. So when we discuss these questions with patients, then we're capturing that data as part of the patient's record and as part of the clinical documentation for assessment of need for patients. And there's scoring guidelines and very specific ways of helping us to identify areas that would need follow-up discussion with patients. But generally, it just leads us for a standardized way of having a discussion with patients about their general well-being and some of their needs. And it really helps us to be to have a very similar conversation at this stage with patients uniformly. Next slide, please. So since we established the program, we really did want to make sure that we're kind of staying true to some of those guiding aims around kind of being able to self-evaluate what we're doing. I don't expect anybody to be able to read all the details of this poster that's posted. However, we do have an abstract that was submitted to ASCO in 2019, and that's available on ASCO's website as well. But it's really around the feasibility in our early evaluation of a survivorship care plan model that has this component of a personalized assessment at the end of therapy to kind of guide the identification of needs and direct to patient's care. And really what we found in this very small evaluation was, one is that we proved the feasibility of utilizing a standard tool in our workflow that really facilitated conversation with patients. As you can imagine, if you look closely at the FACT GP questions, there's a question that's incorporated into this survey instrument that is around sexual health. And you can imagine how that conversation, can oftentimes be overlooked. And so kind of, we systematically work through the questions. Patients are asked that they don't have to answer the question, but it has been helpful that we ask patients about all aspects of their lives and their well-being. And, the feasibility of using a tool like this instrument really helped us to identify needs that sometimes would go overlooked or may not have been discussed. So it certainly was feasible. But in addition to this, we did take an early look at what was the experience like for our patients as they completed their therapy, and there was this time period that it's kind of like, you're given your next follow-up visit, and you're given these recommendations for what your next step is going to be, but you're not going to be coming back and seeing your nurses and your physician for a more extended period of time. And so what we looked at was the patients that before we implemented the program, and then after the program, those patients that were provided survivorship care, that we did experience. We did show that there were fewer patients that were using the emergency department services and more acute services than after. And so I think that it just kind of, it's not always definitive as far as, the significance of it. However, I think it just pointed us in the direction that there may be an impact of having a very robust and sound assessment and discussion with plans and identifying their full needs, and also those psychosocial needs about their anxieties and their worries. And, what if I experience shortness of breath? What should I do? And that it's okay to give us a call. They can speak with our survivorship nurse, and they can help facilitate a connection with the clinical care team should they need. And that we're not, our clinics aren't leaving patients behind and in this transition, and that we're still there for them. So I think it just really, spurred an interest and an itch for us to really evaluate further. And so that's why I really think that the opportunity to look at this program and kind of the effects since 2018 are particularly interesting. Next slide, please. And next slide. So just to kind of jump into the specific aims, we really designed this around 2 specific aims of this project. So really having a descriptive and kind of qualitative piece where we're looking at the survivorship care delivery. There's a lot of variation that exists even amongst, certainly across the country, across the state of Pennsylvania, and certainly within our own healthcare system around the resources that are at our disposal to design the delivery of survivorship care. And we felt it was important to kind of try to really aim to describe the delivery of survivorship care, both in a multidisciplinary clinic setting, and then perhaps in a community setting, or in various settings that were utilizing different staff to deliver care. So it was important to describe that there's no cookie cutter to this, and I think every program develops their own little their own way of doing it. And uses their resources to the best of their ability to really provide the best care. So we really, we're going to conduct this with the help of Temple on doing staff interviews and really understand those business processes and the resources that are used. In aim 2 of the project component is really that qualitative or the deep dive into the data, as Maggie had said. So, reviewing, assessing the kind of the activity that occurred after that assessment for patients that went through a multidisciplinary clinic model. Utilizing our registry data, we can identify patients that essentially would fit some eligibility criteria. So patients that would have been eligible at the time to be referred for survivorship to a survivorship clinic versus those patients that did get the survivorship referral and were seen, and kind of understand, did patients access similar types of services and what were those differences? And also, how many of those patients got referrals and where did they come from most frequently? So we'd really be focusing in on our top 5 cancers that are at our campus and looking at those patients. And I think we're talking about, this type of quantitative analysis would be inclusive of hundreds of patients over this time. So it really is going to be a very interesting and thorough analysis, and we'll try to leverage every bit of expertise that we have in kind of extracting available data for the analysis. And maybe it will tell us things that we already know. We're all very busy in this aspect of providing care for our patients, but it may provide some insights into things that we do well or things that we could improve on. So it's we're very open to kind of looking at the results in a very transparent way. Next slide, please. So I'll hand it off to Christina to talk about the intentions of aim 1.
Okay, thank you, Mark. Again, my name is Christina Reardon. Myself and my colleague, Fern Gilkerson, are the sort of 2 people from Temple University, Harrisburg, who are partnering with Department of Health and Geisinger on this project. And I wanted to just first start with just a very brief overview of what we do at Temple University, Harrisburg, because I know that I'm sure most, if not all of you, are familiar with Temple University's main campus in Philadelphia, but not as many of you may know that we also have a presence in Harrisburg. And what we offer in Harrisburg is a variety of services and programs aimed at both individuals and organizations at the local, state, and national levels. For example, we offer certificate programs, professional development courses, and conferences, both in person and increasingly online. And some of the programs you may be aware of are our grant writing program, certificate program, our strengths-based leadership program, and our community health worker training program. And sort of more focused on this particular project, we also offer project management and administration services, along with training and research and evaluation services. And I also included our website on the slide there if you're ever curious and want to learn more about what we offer in Harrisburg. Okay, next slide, please. So Temple has sort of three main roles in this particular project. First is project management. So our work in this area is that we organize and facilitate the meetings between ourselves, Geisinger, and Department of Health. We lead team planning process and we develop tools to meet deliverables. We help track progress, and we also sort of help serve as a connection or a liaison between Geisinger and the Department of Health. Really, in that role, we're really just trying to keep the project on track and moving forward. I specifically am most involved in the second bullet you see there, which is the qualitative research support. As Mark mentioned, the first aim of this project is to really get a view of how cancer survivorship services are currently managed at Geisinger. So that's sort of an area I will be in charge of in terms of conducting interviews and focus groups with administrators and clinicians. And then Temple also will be involved at the end of the project in terms of data reporting and developing that white paper that Maggie mentioned earlier, describing the data collection process, results, and recommendations for best practices, and really sort of creating that product that can be of use to other health systems and other organizations throughout the state of Pennsylvania. Okay, next slide, please. So in terms of aim one, the qualitative research support, like I've mentioned before, the sort of goal of this particular part of the project is really to sort of get that bird's eye or 30,000 foot view of how cancer survivorship is managed at Geisinger, looking at questions such as how patients enter survivorship care, what services are provided, in particular, what barriers do patients face in receiving survivorship care? Maybe why are some patients able to receive care and maybe others are not? And also, how do patients transition out of services? And we are also going to be looking at the impact of COVID-19 on our survivorship services. This, of course, was not something we had originally planned to look at when we started talking about this several months ago, but obviously it's something that has affected services and is important for us to take a look at. Next slide, please. So in terms of the sort of overview or looking at how survivorship services are managed, I'm going to be focusing on 3 sites within the Geisinger system, Danville, Wilkes-Barre, and Hazleton. And we decided to look at these 3 sites because not only do they serve sort of different geographic areas and different populations within Geisinger's service area. As Mark mentioned, they also have different delivery models for survivorship care. So we wanted to sort of take a look at each and see sort of what are the similarities and differences between each of those sites. So the plan is to conduct interviews and or focus groups with administrators, clinicians, social workers, and other people involved in survivorship care at those 3 sites to really gain insight about how that is managed at their particular sites. And also I'll be doing a review of existing program materials such as brochures or previous presentations, sort of looking at sort of written and printed material in addition to doing the interviews. And I'm expecting to begin work on this project this summer. So probably, within the next few weeks, getting going with the interviews and focus groups. And I think that's it for my slides. And so I'll hand it back to Mark.
Yeah, thanks, Christina. And I think your work starts today, actually. So she's eager to get started. So it starts really with this presentation and kind of introduction to the CAB and PCC members today. And so the second aim is specifically, we really, at Geisinger, we have an internal health economics evaluation group. And Dr. Howe is an assistant professor at Geisinger in our Department of Epidemiology, Health Services Research, and her interest, she's done research in the past around along the cancer care continuum, and really around kind of that personalized health and some of the implications of the adoption of personalized medicine, genomic medicine in cancer care delivery. And so she's really excited about an opportunity to provide an evaluation on survivorship care. So for the quantitative piece, she's really looking at using an implementation science framework for the analysis, which is REACH, effectiveness, adoption, implementation, and maintenance. And it's really it's kind of a public health approach that many of you may be familiar with. If you're not familiar with, it's easy to Google the details on the REAIM framework. But it is really a helpful framework for just thoroughly describing the effectiveness of program implementations, which I think is what we really want to achieve here. So we'll look at, it'll allow us to evaluate the effectiveness of the survivorship care interventions, and really were patients able to be facilitated to referral or to resources, and then also look at those patient level assessments when it comes to the FACT-GP. So an interesting component of our program is that we not only aim to do a baseline assessment using the FACT-GP, but we do interval assessments. So patients are generally in our survivorship program at Danville. They're included in that model for a 2-year period that we continue to do follow-up, and that we administer the assessment. So at baseline, and then 6, 12, 18, and 24 months, we're capturing within routine discussion, we're capturing FACT-GP results. And as you can imagine, the needs of an individual patient are going to change over time. And so it's important to reassess kind of where things are and how do we make sure that that plan is flexible in meeting the patient's needs, and that we're executing referrals. So it'll be interesting to be able to describe how patients have transitioned over time, and kind of use a survey instrument to capture that. But we're also looking at, there's been changes with survivorship care plans as far as from the Commission on Cancer, and some updates around that. It doesn't change really our thoughts and around survivorship care planning and the ideals of providing good clinical care for patients after therapy. So we're going to monitor the completion of survivorship care planning, look at the continued use of survivorship care plans as a way of documenting and helping patients plan for their follow-up. And we'll kind of do a 18-month baseline period that was at the start of our 2018 program, and a cut point that's in March, around the time of that the health system started responding to COVID. So we'll kind of have a prospective period that we're going to let run out, and then we'll collect the data and include that with our final analysis on kind of a pre-post kind of impact on survivorship care planning processes. And next slide. So lastly, I certainly, I've spoke about our program, but really it's the work of so many different folks at Geisinger that have designed this. And for many of us on the phone, and part of our health systems and the familiarity with our own survivorship care plan delivery, or our survivorship delivery, there's so many individuals that are involved with this aspect of providing clinical care. And I just want to acknowledge and with some of those folks that are part of that program. And so this one slide's not clearly enough to list all the folks that are involved both in the program planning, the delivery of survivorship care plan, and also our partners that are going to help us to continuously improve our program and the evaluation. So I really appreciate all the commitment from the Geisinger team and our clinicians and our staff around this effort. Next slide. And I'll stop there, and Kate, we might be able to field any questions, and if we can. If not, we can always follow up with anybody that has questions.
Sure, Mark. There has been a couple that have come through the chat, so I think we have time for a few. The first one was regarding substance tobacco use, and is that in the new survivor need assessment? and just a curiosity on any data of how many survivors continue to smoke.
I think that's a good comment. It's not part of the assessment, but it is part of our, within our survivorship program. It's part of the education that patients receive around smoking cessation. As you can imagine, occasionally the data that's populated in an EMR can be a little bit inconsistent around smoking or tobacco use and current status of tobacco use. So I'm making note of this so that we can discuss it as an evaluation team and see if we can include the use of tobacco products and the status of patients in the analysis.
Thank you. And then another question regarding, are we considering the cost of survivorship, like the problem of surprise medical billing that's now in the PA House?
So the helpful thing around having a health economist as part of our evaluation group is that we may have an opportunity to look at least from a perspective of those patients that are also Geisinger Health Plan members. We can kind of look at the costs associated with those things. I'd have to, I would appreciate some follow-up maybe around the specifics of the surprise medical billing and maybe how we kind of work that topic, through our evaluation team. So folks can always email me with their questions or provide a contact information.
Great point, Mark. And even some other questions regarding some pieces related to out-of-pocket costs. I think that kind of goes paired together. And I think just one more question, and then we'll defer the remaining questions in our follow-up. But the last one was just really regarding some of the criteria for who was offered to participate. And that may have just a kind of reiteration of that and or part of the follow-up if there was some of that who was offered to participate.
Is that really, I don't know if that's regarding the survivorship program or regarding the mechanism for the evaluation project. I don't know if it's a question for Maggie or whether it's.
Oh, it just popped up. This is Maggie. So we're looking at two different groups. So we have a control. So we're looking at all the patients who were eligible to be referred into the survivorship resource program. And so we've kind of split that into two cohorts. So we have a control group of patients who were eligible for referral, but were not referred. And then we're tracking the patients who were referred and did participate in the program. And so one of the evaluation questions that will be touched on as we do the site evaluations across the 3 sites is why were certain patients referred and why were others not? So that's part of the site evaluation report that will come.
Great. Thank you. And thank you to all of you for this great content. What a wonderful project, and really good things seemingly with the dialogue and that continuation of just how we can work together to expand that. Before we go into the next section of the agenda, we're going to circle back to see if we could have Kelly Holland come off mute and just say a couple words. Kelly, if you're there.
Yes, I'm here. Can you hear me?
Yes, yes.
All right. Sorry about that. I was having technical difficulties earlier. I said to Sharon, I have lost all tech ability, apparently. So I just wanted to say hello to everyone and introduce myself. I'm very happy to be part of this group. As you know, I've come to the Bureau it was in April, so I'm coming up on 2 months now. I'm very excited to be here. Becky and her staff have been giving me lots of information about the programs and this group in particular. Although I'm new to the Bureau, I'm not new to public health. I've been with the department since 2005. I've been in the Bureau of Family Health in a lot of different roles in child and adult health services and the newborn screening program. And so a lot of public health experience, although I am new to this Bureau. And so I just wanted to say hello to everybody and give a little background and let you know that I'm very excited to be part of this group, and I'm looking forward to hopefully a future meeting where we can maybe meet in person. So thank you.
Thank you, and thank you for joining us today. Right. Well, the next section, before we go into that, just, this information, we'll kind of put this up again also at the break, but this is around just a follow-up survey, really wanting to understand just kind of where everybody is through all that we're navigating this year. So just as we came off of some important information from our evaluation committee, a perfect time to kind of plant the seed for this survey, which would be, of course, it was shared before and will be shared post this call for folks to please fill this out. So next we want to talk a little bit about the securing of cancer control funding. So I'd like to welcome Tiffany Cloud, who is from the American Cancer Society Cancer Action Network, covering both Pennsylvania and Delaware, to take us through a little bit about what's going on regarding funding. So Tiffany, could I throw it over to you?
Sure, thank you, Kate. And you can go to the next slide. This slide has two purposes. First, it's the, if you could go back, Kate. One slide. Yeah, if you could go back, there you go. Two purposes. One is the shameless plug. If you could follow us on Facebook, Twitter, and Instagram, our handles ACS Can PA. And secondly, I wanted to start with a slide of our volunteers, because we really are a volunteer-led organization. And many of you likely know that every spring we take our volunteers and we descend upon the Capitol in Harrisburg to advocate for our priorities at the time. This year, we were scheduled to go to Harrisburg in the first week of April. Our priorities that we were going to be discussing were tobacco control funding and access to care. And we had 150 people scheduled to go, including 50 students, which was really exciting, from 5 different schools across the Commonwealth of Pennsylvania. And that was certainly encouraging to me to see just so many of the next generation coming up and involved and interested in our advocacy work. Unfortunately, we all know what happened with regards to COVID. The good news is we were able to adjust and adapt, and we took our advocacy work regarding Harrisburg virtual, and we had a lot of success. So I'm going to tell you a bit about the results of our work as well as what we're continuing to work on. So if you could advance one slide. Thank you. Well, we all agree on this. We will never stop the fight against cancer, and COVID-19 is certainly not going to stop us. Tobacco control funding and access to care are two of our top priorities. Recently, when I put this presentation together, we were still advocating for tobacco control funding to be included in the PA budget. We were advocating for flat level funding, which was $14.7 million in critical life-saving tobacco control funding. The good news is that since this slide was put together, the House and the Senate passed a 5-month gap budget, which was signed by the governor. That just happened a few days ago. They're not doing a full year budget this year because, of course, I think no one really knows what the impact of COVID is going to be from a revenue standpoint a few months from now. Nobody knows if there's going to be a recurrence of it. So they put together a 5-month gap budget. And the good news is, because of the advocacy work of volunteers like ours and other organizations that are on this call, we were able to secure our prorated amount of the $14.7 million in tobacco control funding. So 42% of that funding has been secured in proportion with 5 months. That's the great news. And honestly, I say that because I think we could all guess that every year we have to fight very hard for that funding and to secure funding for tobacco control programs. This year, because of the revenue cuts, we were very concerned that it was at risk more than ever. Now, the job isn't over yet. We are well on our way, having secured that portion of it. But in the fall, we'll have to come back and advocate for the remaining 58% of the funding. So just keep that in mind that we will be coming back. The slides are gone from the desktop. I'm not sure what happened just there. Oh, Kate, you're on mute.
My apologies.
No, that's
It's
okay.
a little technical glitch here.
That's
so give me
okay.
one
No
moment.
worries. And even if you're having trouble pulling them up, I can certainly keep going. It's okay. Oh, no, we're good. Okay.
Is it right here, Tiffany?
Yes. One more. Go back one more to the introduction.
So right here?
No, one more.
Okay.
There you go. Okay.
So
that is the update on tobacco control funding, which is nice. I thought I was going to be coming on this call asking all of you to help us advocate for this money. The good news, I'm able to give an update saying we secured a portion of it, and in the fall we need to advocate again for the remainder. The other thing that we've been working very hard on is we all know that cancer patients require timely access to care, that all too often cancer patients have to wait weeks or even months for insurers to approve treatments or tests that they need to get the care that they need, and cancer patients should not have to wait. So we have been advocating very hard for timely access to care, supporting House Bill 1194 and Senate Bill 920. You could advance, please. Okay, I just want to pop back to tobacco use very quickly so that we're all prepped for when it is time to go in and advocate for the remainder of the funding. Tobacco use is responsible for 20% of deaths nationwide. In Pennsylvania, 22,000 deaths are caused by smoking each year. 18% of adults smoke cigarettes. Nearly 19% of high school students are using tobacco products, with over 11% using e-cigarettes and 8.7% smoking cigarettes. Almost 28% of cancer deaths are caused by tobacco products. We have 5,100 kids under 18 becoming new daily smokers each year. So those numbers are not good and concerning. As we went in to advocate for securing this funding, one of the cases that we made very strongly, our volunteers made very strongly, is the cost impact if you don't have tobacco control program funding in the budget. Smoking is estimated to cost nearly $6.4 billion in direct healthcare costs, including over $2 billion in Medicaid costs. So if you don't put these programs in now, 14.7 million, look at what the costs are. So you can go to the next slide. And even though we are well on our way to securing this funding, by no means is what we're asking for a lot. It's far short of what the CDC recommends. They recommend 140 million because keep in mind, big tobacco is spending nearly $444 million in marketing their deadly products in Pennsylvania each and every year. And you've probably noticed that e-cigarette manufacturers are really targeting youth, especially with their flavored tobacco products, bubblegum and mint, etc. So that's very concerning. And we know that evidence-based statewide tobacco programs are successful. Next slide. Okay, now I'm jumping to our other issue, which is access to care. As I stated earlier, cancer patients cannot afford delays in treatments and tests. According to a survey that the AMA conducted, 92% of physicians report that prior authorization delays have had negative clinical impacts on patients, and 78% have reported that such delays can lead to patients abandoning their treatment. 1 in 3 cancer patients and caregivers report experiencing delays in their loved ones' cancer care. So we have been advocating for and are continuing to advocate for the passage of House Bill 1194, Senate Bill 920, so that cancer patients can receive the timely access to treatments and tests and medications that they need. And we're trying to get 72 hours or less, ideally. Next slide. What's interesting is that COVID has put access to care even more on the radar. So the fact that we were already advocating for timely access to care, and now we have cancer patients even having more challenges related to getting the treatments and tests that they need, has really made this initiative definitely more on lawmakers' minds than before. A recent survey that ACS CAN did stated that it focused on the effects of COVID-19. It found that 87% said the pandemic had affected their healthcare in some manner. That was up 51% over the prior month's survey. And of those in active treatment, 79% reported delays to their healthcare, and that was up 27% over the prior month's survey. And that included 17% of patients who were reporting delays to therapy. So 1 in 4 patients said the pandemic has made it more difficult to contact their providers with questions as well. And 1 in 5 say that they're worried their cancer could be growing or returning due to delays and interruptions caused by the COVID-19 outbreak. I've personally spoken with volunteers of ours who are cancer survivors who have had their mammograms delayed, and they're incredibly concerned about that even. The next slide. So the call to action, I'm going to change this up just a little bit. First, I would like to ask those of you who can to thank lawmakers for securing tobacco control funding in the 5-month gap budget, and to mark those calendars so that you could help us advocate for the remaining 58% that we need in the fall, because we want to have the whole kit and caboodle, the whole $14.9 million. Other actions you can take: support House Bill 1194, Senate Bill 920 to ensure cancer patients receive timely access to care. And the last thing is, we're really looking for story collection. Certainly, if you have any stories related to tobacco usage and the importance of tobacco control funding, please go to fightcancer.org, and there's a story collection link there that you can share stories. Also, importantly, we're looking to gather stories of patients who have had delayed access to care, to treatments and tests, and particularly so during the COVID-19 pandemic. So if you have any stories or know of stories that should be shared, please certainly use those resources. And just thank you, everybody, for all you're doing to continue the fight against cancer during these unique and challenging times. I'm so pleased to see such a successful virtual meeting today. Thank you, Kate, for organizing it.
Thank you. All right. Well, I will say, just to continue to utilize the chat, we are pretty okay on time, a little bit behind, but for good reason. Great content continuing to come in, wonderful questions. I am going to ask that we do not take a full 15-minute break, but we rather come back as soon as possible so we can really make sure that we are beginning our next section of the agenda, our panel discussion, on time. So if you want to take a quick break, come on back. We are definitely going to be making sure that we do, again, start on time. And if our panelists could just stay on to just do a quick check-in with me before we break for a few moments, that would be great. All right, we're going to take a little pause, and while we're up here, we're going to leave this little slide up for folks to check out. Thank you.
Hey, Kate.
Hi, Dr. Coleman.
Hi, can you hear me okay?
I can.
Okay. Sound check is all right. It's clear enough.
Hi, Shikoko. I see you too.
Hi there.
Good. Dr. Reyes, I saw you on the participants. Are you on?
Hey, Kate, I am here. Sound check 1, 2, 3.
Fantastic, and nice to meet you. And then Laura, are you able to hear us? All right. And then Peg, are you still there too? So I can
Kate,
check.
it's Peg.
Hi, Peg. Very good.
Yeah, I keep getting muted on and off, so I'll just keep trying.
This is Pat Halpin Murphy, and I am still here.
Fantastic.
Okay, thank you.
All right. Well, thank you. I guess, we can all take a little break. We'll come back a couple minutes prior. I'm going to do a quick introduction and then move right over to Peg as our moderator for our panel today. All right. All right.
Great. Thanks a lot.
See you in a couple moments.
Okay.
Hi, everyone. Just a little reminder that if you are not a speaker, if you could please mute your lines. If you have called in, I may need you to also do a check to make sure that your phone is muted another way. Thank you. My apologies, I was on mute. So I have us at 10:59, and in the interest of time, I would like to get us started with an introduction to our panel. And I'm so excited, of course, to welcome in this section of our agenda and to the wealth of information that will be shared with all of you this morning. Because of time constraints, we are really going to ask that we utilize that chat box for questions that do come in. Part of our panel portion of the agenda today will include an open discussion and time for Q&A after our 4 panelists have time to speak about what is going on specific to their institutions and areas. So at this time, I would like to introduce our panelists. Full bios will be made available after the meeting, but I would, of course, like to share a little bit about each with you. So first we have Dr. Larry Schulman. He is the Deputy Director of Clinical Services at the Abramson Cancer Center at the University of Pennsylvania and Director for the Center for Global Cancer Medicine. He's a leadership role in the strategic development of cancer services for the Cancer Center and its affiliated hospitals and ambulatory cancer centers. He is also the chair of the Commission on Cancer and serves as the National Cancer Policy Forum of the National Academy. Also with us, we have Dr. Vincent Reyes. He is the Assistant Medical Director for the UPMC Hillman Cancer Center Medical Oncology, an Assistant Clinical Professor of Medicine at the University of Pittsburgh School of Medicine, and serves as a Managing Partner for the Hematology Oncology Associates. He's an active member of our physician community at St. Clair Hospital in Pittsburgh and serves as their Division Chief of Hematology and Medical Oncology, and sits on the Quality Cancer Conference and Blood Utilization Committees. We also have with us Laura Toole, who is an oncology social worker with over 30 years experience and the Executive Vice President of the Northeast Regional Cancer Institute in Scranton, PA. She works with an interdisciplinary team in the development, planning, and implementation of cancer education programs and materials for cancer survivors, their families, health professionals, and the general public. And we today, to round out our panel, have Shiyoko Cothran, who has more than 19 years experience in leadership of academic medicine. Since 2011, she has served as the Operations Director at the Penn State Cancer Institute and the Associate Director for Administration since 2013. She plans, directs, and executes all administration and financial activities for the Penn State Cancer Institute. Shiyoko has taught residents on the concepts of healthcare administration and as a senior instructor to the Department of Psychiatry and Behavioral Health. To take us through our panel as moderator, we all know very well Peg O'Grady, who is our vice chair. But for those that do not know Peg, and this is maybe the first time you're meeting her, she is, of course, the vice chair of our Cancer Advisory Board, and she is currently the administrative director of the Abington Jefferson Health System's Aspen Cancer Pavilion. Peg oversees the inpatient and outpatient oncology service, including a robust research relationship with the Sidney Kimmel Cancer Center. So thank you all for joining us today. And Peg, I'm going to kick it over to you to kick us off for our panel.
Thank you, everyone, and thanks to the panel for their time and effort today. Just to set the stage a bit, we want to make sure that you understand what the panel has put together as far as content and information. So what this group is working on during the COVID-19 crisis is literally the strategies to prioritize patients, prioritize the use of technology such as telemedicine, to really look at how we can impact clinical trials and research for plans to resume and ramp up care as well as ongoing care within your specific cancer clinics or hospitals. Critical to this success was creating a safe environment during COVID-19 and now post-COVID-19. I know a lot of us have had discussion about screenings in particular, so routine preventative cancer screenings as well as resuming ramp up per institution for the impact of COVID-19. We also want to take a look at our own staff. It was critical to success that the staff feel safe during this point in time. And then we really want to open up discussion with the panel based off of their best practice methodologies. So we thought that absolutely the best point person to initiate this discussion was Dr. Schulman, who has done such extensive work at the University of Pennsylvania, and we welcome you, Dr. Schulman, to begin the session.
Thank you very much, Peg. Can you hear me okay?
Very clear. Thank you.
Good. Thank you. Thanks for having me. If we could go to the next slide, please. So I don't have to tell any of you that this has been really an unprecedented time in all of medicine, and particularly in cancer medicine. And we're learning as we go. And there's a lot of things that we are beginning to understand, but there's also a lot that we don't understand all that well yet. And we're trying to pay as close attention as we can to what's going on so that we can provide the best care for our patients in the safest environment for them and our staff. So a couple of things that I think are fair statements on June 11th, 2020, and they could be different tomorrow, but this is sort of how we're thinking about things now. When we look at our cancer patients, and they ask us all the time about this, there's not a clear increased risk of them contracting COVID. We've tried to look at this, but population studies are very flawed in this country as well as in China and Italy and elsewhere. But we do caution them about being exposed because many of them will have altered immune systems. We do know, though, and I will show you some of these data in a minute, that patients who have active cancer who become infected with COVID have a much greater likelihood of serious complications and of death. And in fact, they have a more rapid progression of the infection. And this is particularly true for patients who have hematologic malignancies like lymphoma and leukemia and lung cancer. It's not clear if cancer survivors are more likely to have serious complications, but the data are worrisome. Earlier in the program, you heard a lot about Geisinger and Temple's survivorship program. There are 17 million cancer survivors in this country at this point, and all of us who take care of cancer patients take care of many of those. And most of us have advised them to be extra cautious about exposures. There's some evidence that they may be more at risk for serious complications. We also know that for patients who are infected with COVID, who undergo surgical procedures, including cancer surgery, have a very high likelihood of death, which may be as high as 25%. And most of us, including at the University of Pennsylvania, are testing all patients for COVID infection prior to any significant surgeries. But our concern is that there's a fair false negative rate in the testing, so we're not picking everyone up. Next slide. So this is a study from Wuhan, China, which, as you know, was the first major area of infection that was presented and published in April. And the reference for this you can see at the top if you want to look at the full publication. If you go to the next slide, please. On the left, you can see the percentage of patients who have death or ICU admissions or severe complications, and the purple line, the highest in each category, are those patients with hematologic malignancies. The red line, second to that, are patients who have lung cancer, and so on. And you can see that for patients who have hematologic malignancies, nearly 70% of those patients, over 2/3 of those patients, had serious complications, and about 35% of them died if they were, in fact, infected with COVID. So very, very high rates of serious complications and mortality. On the right, you see the rapidity of developing serious complications, and the green line, which goes up more quickly than the others and to a higher level, are patients who have metastatic cancer. So clearly having active cancer, particularly hematologic malignancies and lung cancer, put you at great risk for poor outcomes. Next slide. So actually back in March, Cancer Care Ontario, which is a very active and progressive cancer program to the north of us, developed and published something called the Pandemic Planning Clinical Guide for Patients with Cancer. And you can see this was actually published in mid-March. Go to the next slide. What they did was they divided up patients into 3 categories: priority A, B, and C. And as I will show you, this has been used reasonably widely across the US now, as well as in other places of the world, to help us understand how best to manage our cancer patients. Priority A are patients who have critical conditions that require immediate treatment regardless of the situation. And these might be patients who have spinal cord compression or neutropenia and fever or hemorrhage. And those patients need to be taken care of quickly and effectively regardless. Priority B are patients who require services, but the situation is deemed non-critical, and delays that are modest will not affect their overall outcome, and their care should be maintained according to that. And priority C are patients who are generally healthy, whose condition is not life-threatening, where services can be delayed significantly without altering the outcome. Next slide. So a number of us in the US have tried to create guidelines to help us to understand how best to manage patients during the pandemic. And though all of us, particularly in Pennsylvania, are feeling a little bit relieved as the infection rates go down, it's pretty clear that COVID is going to be around for a while, and we're all worried about potential second waves. So these guidelines remain relevant and need to be at our fingertips to help us to understand best how to manage our patients. This is one that myself and colleagues from the Commission on Cancer and NCCN and other organizations published in April on recommendations for prioritization, treatment, and triaging of breast cancer patients. And the reference is on the top of this slide as well. If you go to the next slide, what we did at the University of Pennsylvania is that we asked all of our disease groups in March to form COVID multidisciplinary urgent teams, including surgery, medical oncology, radiation oncology, pathology, radiology, and other associated services such as pulmonary for lung cancer or endocrine for thyroid cancer, and to pull those teams together very, very quickly and to create what we called COVID-specific pathways that would be disseminated throughout the Penn network. These, I will show you an example in a couple of minutes, were developed literally within 1 to 2 weeks, published on our Pathways website. And since then, we've run a series of webinars that have been meant to help providers within our own system and outside of our system to better understand how to manage their patients. All of this was balancing the needs of the patient and how acute they were, what we thought the infection risk was of either bringing the patient into the hospital, either as an outpatient or an inpatient, and undergoing major surgery. As I'm sure was the case with most of you, surgery was most restricted, partly because of resource constraints in the hospital. Radiation was able to be continued to be delivered almost at the usual pace, but systemic therapies were often altered because of risks to the patient and also trying to minimize clinic visits. Next slide. We also were very concerned about a couple of things. One is that for patients who are having their therapy delayed, we did not want them to be lost in the system. And so we created lists in our EHR that categorized all the patients from March 1st on who were either receiving treatment on time or had some component of their treatment delayed, and the component was specified in these smart phrases that were created so that we would know whether surgery was delayed, or radiation or systemic therapies. And we also had a prioritization system so that we knew that patients who were high priority would be called back sooner than patients who were low priority. We created REDCap databases, and Penn, like many other institutions, is a research institution, and we wanted to best understand how many patients had their care impacted by the COVID pandemic and what the effects of those impacts were, and those research efforts are ongoing. We're also participating in COVID-related databases with the National Cancer Institute, the cooperative research groups, and ASCO. Next slide. So this is just an example, and it's not meant really for you to read it, but this was the COVID pathways for our lung cancer group, and you can see at the top it says COVID-19 pandemic, best practices for lung cancer care. And this, in fact, is just a snapshot of the first page, but included interventional pulmonology, surgery, medical oncology, and radiation oncology. And you can see here that under surgery, it talked about who should proceed immediately with surgery and who should get alternative therapies such as stereotactic ablative radiotherapy as an alternative to surgery, and so on and so forth. And it goes through all the potential treatments for lung cancer, and these were made widely available throughout our system. And actually, this was published by the Journal of Clinical Oncology's Oncology Practice Journal emergently, so this could be shared both nationally and internationally. Next slide. And this is just a snapshot from the heading of that article, but we also can get you the abstract or the reference for this, but this was the work that was published in JCO Oncology Practice. Next slide. So the question is sort of now what? And as I mentioned, I think none of us are secure in understanding what the future is going to hold as far as the infection rates and the restrictions that are going to be facing our patients and also facing our healthcare delivery institutions. It's likely the virus is not going to disappear. We don't know what level it's going to be at. We don't know whether there will be second or third waves. And so I think agility and adjustment to the environment is going to be critical for all of us. We are, like most other institutions around the country, starting to scale up and increase our in-person visits and our inpatient admissions and our surgeries for cancer, as well as screening with mammography or colonoscopy or other interventions. But we're watching all of this very carefully, and we're continuing to weigh the risks of cancer versus the risk of delay in diagnosis, treatment, and surveillance, the risks of infection spread to patients and staff, and the risk for infected patients to undergo surgery, systemic therapies, or radiation. We're watching the resources within our own healthcare institutions and adjusting appropriately, and obviously there are public health concerns as well. So I think the bottom line here is there are lots of unknowns. We're all doing the best we can. We're all trying to learn from each other. And I think with that, I think that's my last slide. Thank you.
Dr. Shulman, thank you so much. What we will be doing is going to the next speaker with the thought that we'll get all four of you for Q&A post. But thank you. Our next speaker is Dr. Reyes, who is the Assistant Medical Director at UPMC Hillman. And his discussion, I think, gives us a little bit more technology as well as clinical trials and what are some of the angst during COVID. So Dr. Reyes, please, thank you so much for your expertise.
Thanks, Peg, and thank you for having me to this very illustrious group. I'm hopeful that I can meet you all in person next quarter. Hopefully we'll be able to see each other in person. And it's quite the honor to follow Dr. Shulman's presentation. That was really wonderful to talk about COVID-19. And I just want to echo that there's just so much unknown about COVID-19. And I'm not going to say we're making it up. But it's absolutely correct. We're doing the best we can with the best and the brightest to try to make sure that we're doing what's best for the patients and their outcomes. So what I want to do is just concentrate on a few items just to make sure that, with a limited amount of time and also with the constraints with technology and staring at the computer, that we just focus on a couple of things that like telemedicine and clinical trials. And I have to apologize ahead of time if you hear my children yelling or dogs barking. I apologize ahead of time. Next slide, please. So just to talk about UPMC Hillman Cancer Center and just give you an idea of who we are. We believe in the hub and spoke model. So basically, Hillman Cancer Center is our mothership in Pittsburgh, but then we also have multiple sites throughout southwestern Pennsylvania, and actually go into Harrisburg, a little bit to New York, a little bit in Ohio, a little bit into Maryland, where it's designed so that patients can get the same care no matter where they are in those centers, be it medical oncology or radiation oncology. Now, there's still niche things that you still have to go back to Hillman Cancer Center, like CART, bone marrow transplants, and certain surgeries. But we want to make sure that the processes, protocols, talent, pathways are all the same no matter where you go. In our catchment area, we have over 30,000 unique patients that come outside of the Pittsburgh area. So it's really important to make sure that people are getting the same level of care throughout. But also, it means you have a lot of resources that you can leverage to try to create processes to make sure that everyone is getting the same care, but it also makes it a little bit difficult to move the needle because you have such a diverse network. And you see this for some places like in Pennsylvania, where for COVID-19, Pittsburgh actually really wasn't as affected to COVID-19 as, say, other places in the state, like Philadelphia and Harrisburg. So how we're doing things are maybe slightly different than what was happening in Philadelphia and Harrisburg, because every region in the state is almost like a different country almost. But just so you know, we're the largest integrated community network of cancer doctors, and we have more than 60 cancer centers. Next slide, Kate. So one of the things I wanted to talk about was telemedicine. And I can tell you that I was one of the biggest proponents of telemedicine for the past 2-3 years. We had a little bit of it in Hillman where we use it for second opinions, for stroke, for places that are underserved. But there's a lot of barriers to telemedicine, specifically for reimbursement was not on par for seeing in person. There was technology that was a little bit not ready for prime time. But because of COVID-19, we had to ramp up fairly quickly. Now, when you talk about telemedicine, it can mean a lot of things. It can mean you pick up the phone and call someone. That is considered telemedicine. But what we think about it from our patients and from your families is that you're seeing someone on your smartphone or on your computer face-to-face with your doctor. And that's what we tried to do. Now, when you talk about that, there's some definite advantages to that. When you talk about patients being able to be at home, see their doctor, to be able to get their care, it's more convenient. They could do other things. And especially during COVID-19, it was definitely safer for them to be away from other patients to infect them, or also to make sure that they were safe themselves, especially as our PPE wasn't quite where it is now. So it was actually a great way to improve safety with our patients. And I include there our specific platform which is called VidYO, not a plug for them, but just to let you know that that's what we used. And I also want to tell you that even though there's a lot of excitement, we had a lot of issues with telemedicine. And the first issue was pretty apparent right away, is that when we used VidYO, this VidYO platform, it was very difficult for our patients to actually use. Operationally, they had to send an email to the patient would then have to click on it, they had to download the app. Sometimes they had difficult in the virtual waiting room to connect with a doctor. And so it actually created more delays and actually solving more problems. But we persisted because we wanted to see our patients. But also the issue was the platform. So people think, oh, telemedicine, I can just go on my smartphone, I can press FaceTime, and then boom, ready to go. And that is great, that does happen. But a lot of patients don't have iPhones. People have Androids. And in fact, in our southwestern Pennsylvania, a lot of them have flip phones. So they don't even have access to a camera. So a lot of different things kind of surfaced that we had to work through. And actually, a lot of physicians in the medical oncology space started to get discouraged when using it because of all these different barriers. The other thing that we noticed was when it came to telemedicine, it really didn't take off because we do things differently on the oncology space that other places like, say, primary care or endocrine or other specialties use. A lot of our patients come to our office to get things like port draws, port flushes, labs, chemotherapy. So we have a very technically complicated multi-stage hospital-based clinics where we give a lot of services that require the patients to actually come into our offices. So because of that, we actually, the patients prefer to actually see us since they're coming in anyways. Kate, can you advance the slide? What we did create, and this was a really nice tool created by our IT department, was a telemedicine volume dashboard. And it was great because it really tracked how many telemedicine visits that we had and how many in-person visits we had. It's been de-identified, but also it actually tracked cancellations during COVID-19 and why. And why they cancel? Was it because they were scared, because they didn't think it was safe, or there was family members? So a lot of drop-down boxes to try to get information of what was actually their concerns. And it was a really nice way to try to leverage technology to try to help us try to understand what was going on. It was actually a great tool to try to see our volumes. And we actually, it was a great tool for leadership, but also for physicians. And one of the things that we saw that telemedicine for all the volumes is only up we used about 30% of all visits versus in person. So we really did not take off unlike other places. And then right now we're actually down to almost less than 1% telemedicine as far as using it for volumes. The other thing that I want to stress about telemedicine is that there's certain things about the in-person visit that you cannot replace by seeing them face to face. Number one is a physical exam. And I can't say how many times that we need physical exams to see our patients. Also, you know, the slight nuanced physical cues that you see with your patients, be it their color, be it their family member giving the eye roll because the patient's not telling you the whole story, is really helpful to me to try to figure out what to do as far as next therapy. So all these things of just holding the patient's hand while you give them a diagnosis, I don't think can ever replace telemedicine. So I don't know what space will look like down the line at UPMC Human Cancer Center. I don't think for the medical oncology, radiation oncology space that's going to be a big player, but I do think where the opportunity is in other supportive measures where there's some limited resources, and you can use it for places like palliative care or for behavioral health or for genetic counseling or even for reproductive health, because there's such a limited amount of resources to actually get these patients to come in to see these patients, but also for those physicians or resource staff to see the patient out in the community. It's actually great to use telemedicine as a vehicle to try to increase access. And it's one of those things where the more we can actually continue telemedicine in those avenues would be wonderful. And I think that a big piece that has already been said is that the more that we can keep reimbursements at the same levels in person, we can actually, with insurances, we can actually continue telemedicine and give the physician, the patient, the choice to decide how they want to proceed. Kate, can you give me the next slide? Thank you. I also want to mention clinical trials to change things a little bit. This is actually a group called HOA. There are about a 30 physician practice within the UPMC Home and Cancer Center out in the community. And we had a really big initiative to actually increase clinical trial accrual. And as you can see, from 2015 to 2018, it really wasn't that great, between 100 and 200 patients. And we were actually tasked to actually increase trial accrual. And we did a number of different strategies to try to increase accruals, and it worked very well. It was very successful, this group, and now we're actually implementing it across the network. As you can see, last year we were up to over 600 accruals. That's a threefold increase. And in 2020, we were actually at 500. So we're almost in a 6-month period where we were last year. And this is actually really important for leadership, because not only is it good to get people on clinical trials, but also you can figure out where you can reallocate resources as far as clinical research coordinators and where you want to devote energy and time, because if there are sites that are not going to accrued trials, patient trials, and there's no need to even bother going there if traditionally and historically they're not going to do anything. But you can really focus on where the areas where you want to get people on trials when there's buy-in from the physicians. Next slide, Kate. And this is what happened during COVID-19. In January and February, this particular group of physicians was doing great, over 150 in January, over 170 in February. And then when COVID-19 hit, everything just stopped and plummeted. I think that there's a number of reasons, a lot of reasons you can think that's very intuitive, and that is the physicians had lack of buy-in during that time. They were preoccupied with COVID-19. The patients were concerned. There's a lot of fear. There's a lot of unknown. And also a lot of the change in practice patterns, as Dr. Schulman mentioned, is, for instance, for patients with early stage breast cancer, they weren't getting surgery right away. Some with ER positivity were starting on Arimidex for 3 months and then getting surgery afterwards. So how we were doing things were different, which would exclude people from clinical trials. So there's a lot of different factors for it, but it also represents a great opportunity to try to relaunch as we learn from this to see, hey, maybe the CRCs can use telemedicine to talk about protocols with patients at a distance instead of having to be there physically, or maybe it's an opportunity to look at the consent process, to look at e-signatures, or even perhaps to think about a less rigid requirements to get people on clinical trials. When patients go on clinical trials, it's very, very specific. A CT scan or PET scan within 30 days before enrollment. And sometimes patients get a CT scan or PET scan at 32 days and they're outside of that window, and they have to repeat a scan just to get on trials, which is not only costly, but also hard for the patients too. So maybe there's some flexibility that we can learn from all this to try to decrease the rigidness so we can increase accruals. Also, I think that we can also learn from our processes, and I think that we can actually use what we learn here to try to increase accruals and make people more aware of clinical trials, because this is the lifeline of oncology. To get patients on clinical trials help people down the road. It advances our science, and it's absolute importance that we get people on clinical trials, and we do in general a poor job of getting patients on clinical trials, and that's where this group is very important to help promote clinical trials, to help patients understand what they are, but also to know that it's still safe to go on clinical trials even during COVID-19. Next slide. This is another interesting situation that we noticed at Hillman, and that is our volumes have been picking up very nicely. And actually the data shown earlier about how things dropped as far as volumes and patients seeing their physicians pretty dramatically in March and April, we're starting to pick up. At Hillman Cancer Center, we're actually right at our pre-COVID volumes almost, but what we're seeing is action of patients who will not come in. They're just either too scared, too concerned, their family members won't see them, don't want them to come in. But more importantly, there's also, as the systems are starting to increase their capacity, there's bottlenecks are occurring from CT scans aren't being able to be done, or mammograms. And then the patients, since they're not getting their appropriate testing, they're delaying their appointment to seeing the physician. So we're trying to do is at Hillman is we're doing this this grid that you see here. You don't have to know about it. It's just give you the scope and the breadth of what we're trying to do is trying to touch many different areas to make sure that patients know that they should be comfortable about coming back to the offices, to make sure that they get their healthcare back on schedule. And we're doing it with people that they trust, their own doctors and trusted leaders, to get on TV, other medias like the newspapers, and other forums like town halls, to make sure that they know that we are here, we're still seeing patients, it's safe to come back to our clinics, and they should get their healthcare back on track, because we do know that cancer won't wait, and neither should they. With that being said, I think there's also another piece that has to be addressed, and that is screenings. Cancer doctors, when patients get chemotherapy, they're pretty much coming. But for new patients, that's where the real concern is, and that is what's happening to these patients as we delay their colonoscopies, as we delay their screening mammography. Are we going to see more advanced cancers? And that's the biggest worry, that the longer we wait for those things and the longer patients see their primary care doctors, the longer it's going to get them to eventually see us, which we don't want. So the more coordinated effort we have to try to get the message out, I think that's going to serve us very well down the road. Next slide. So just as conclusions, just to make sure that we can speed this along, and I just want to let people know that I think a more targeted, risk stratified approach for COVID-19 is what's needed here. I think, as I mentioned before, it's different from what we're doing in Philadelphia and Harrisburg and in Pittsburgh because of densities, exposures, everything else. And I think that when you talk to the government, especially local government and state officials, is that if there is another surge or if something else happens, we really have to not use a blanket statement that say, hey, no surgeries. I think that for cancer care is essential. We can't shut those things down. We have to let the physicians and the multidisciplinary groups decide what is appropriate for their patients. And as Dr. Schulman said, it's a balance. And if we are restricted in what we can do because of policies, I think that's not the right approach. And I really think that we have to use a scalpel instead of a sledgehammer when it comes to COVID-19. So my suggestion for that is to talk to your groups and make sure that your advocacy groups know that we got to be smarter about how we go about this in the future. Also for telemedicine, I think that we should maximize it for specific situations and give patients their choice. But the only way to be able to do that, my suggestion is to continue to talk to state officials to let them know is to keep reimbursements on par, to make sure that the reimbursement levels are the same that they are now, and to continue that and make it permanent so that reimbursements don't fall once everything gets better. Because I think the telemedicine is very important and really probably the future for certain situations. And also the relaxations of HIPAA and also for relaxation of some litigation also lets doctors do their job easier and more effective. So that's something as this group can take a look at as something to talk as well. The third is the reimagined clinical trial accrual. And this is where I think all the advocacy groups, everybody who's on this line, to really make it a point to let their constituents and their patients and their advocacy groups know that, listen, get people on clinical trials, make sure that they know it's important, and make sure they know it's okay and it's safe to go on clinical trials during this time. The fourth is that patients need encouragement because they're scared, they don't know, we don't know a lot, but I think that they need to know that their cancer care can't wait. And I think the more that that's said, the more they know they should talk to their doctors to get there and see their doctors, the better it is. And the more we can get people back on track to make sure we don't miss an opportunity or even miss the window that we can actually take care and treat these patients. The fourth is we need a coordinated approach for this and adapt the strategy to these new realities. The first phase was this emergency phase where we're trying to stabilize the situation, buy time, and come up with things. Now we're in this adaptive phase where we're trying to tackle underlying causes and build the capacity to thrive in this new reality. And I think where this comes in is that we have such a Pennsylvania has wonderful health systems, and from Penn to Geisinger to Temple to UPMC to all of them. And the more coordinated we are together, the better the messaging can be. Because I think that's one of the problems we have is that the message is a little bit disjointed and fragmented. The more we can work together, and I think this particular forum serves as a great stepping stone to try to work together, try to make sure that everyone has a singular message of what we can do for our cancer patients. So with that, I just want to thank everyone for allowing me to speak. And I want you to know that everyone on this call are complete heroes when it comes to making sure that the patients' voices are heard and making sure on a higher level that we're able to hear and make sure initiatives go through to make sure that they're safe and their cancer care is taken care of is a wonderful thing. So thank you for having me.
Thank you so much, Dr. Reyes. We really appreciate the expertise and the different slant on COVID and its impact in the Pittsburgh and surrounding region. I would ask again that we continue to hold on questions. We'll get them towards the very end. What I would like to do is move forward with the Northeast Regional Cancer Institute lecture. Next slide, please. Okay. I'm sorry, next slide, please.
Oh.
Okay. And I would suggest that we bring on our next speaker.
Laura, are you there?
Laura, are you available? We've had some hearing difficulties in between.
Mm-hmm. Okay.
You want to skip and move to next?
Sure. All right. So Laura, we can circle back. I'll try to work with you offline to see if we can come back to your presentation. And then Shioka, will move to you.
Great. Thank you. Good afternoon, everyone, and thank you very much for having me today. I appreciate the opportunity. Next slide, please. So the Penn State Cancer Institute identifies its 28 county catchment area. You'll see that in the map to the left. This is the territory that we work in most often. It is the counties that we draw patients from. It's counties that we draw research subjects from, and it is counties where we have ongoing relationships and educational opportunities. One of the things that we've done throughout the COVID pandemic is tried to reach out to the folks that we've worked with over many years in these counties to make sure that we were supplying them with information that could be helpful. As you'll see, though the data is a couple days old, there is a variety of different. Each of our counties sort of experienced COVID a little bit differently and had different cases and impact. We've tried to engage some of our community advisory boards, those groups in different areas that provide the Cancer Institute with important feedback and guidance. We've tried to engage our community health workers and lay navigators, and we've tried to engage local media to help us send a message to cancer patients that they should stay engaged with their care. They should stay engaged with their care provider and make sure that they're following up when they are in active treatment. Next slide, please. So our previous panelists were some wonderful physicians and were able to give us some great content. I'm going to sort of take a little bit of a tactical viewpoint, being an operations person. So for all of you operations people on the call, I'm sure that you recognize that this pandemic has really been an exercise in lean opportunities and lean processes taken to an extraordinary level. So lots of opportunities where we once might have looked at a process over a week, say a rapid improvement event. We found ourselves having to take hours to determine how to reduce the touch points from patients coming into the clinic, through our clinic, and out again in a safe manner. As the previous panelists have said, we really focused on how to keep patients and our staff safe, and really the importance of staying connected to our patients. Our disease teams were engaged, much like Dr. Schulman said, to make sure that all of our oncology experts were in line with each other. And then we really counted on our provider and nurse dyads to ensure that all of our patients were being properly attended to. So that meant those who were on active treatment were encouraged to maintain those schedules, and those that were coming in maybe for a 6-month or 12-month follow-up would get a telephone call, or we would delay that appointment. So lots of different opportunities on how we manage those patients. We relied, of course, on our IT colleagues, another group of maybe unsung heroes, as we tried to utilize telehealth. Our organization, much like you heard from Dr. Reyes, our own organization does have its own telehealth platform. But before COVID, it had been used in very specific clinical areas, and we had not utilized it here in the Cancer Institute. What may have been pre-COVID a 18-month rollout really became a 2-week, 14-day rollout for our use of telehealth. We also tried to make sure that we were engaging all of our capabilities. So we often utilized some of our learners within our College of Medicine and in the Milton S. Hershey Medical Center to help us with some of this work. As you can imagine, our medical students have lots of experience in using IT services. They actually helped some of our faculty and patients sort of get up and running on our telehealth platform. That helped them engage with the patients and help them, become part of the clinical team at a time when they were asked to step back from their in-clinic and in-hospital learning. So we were happy to have them engaged. Next slide, please.
Oh, my apologies. So here we go. Some technical stuff going on there. Sorry.
Okay. So again, for our, inpatient services, I guess what I'd like to sort of focus on is how we tried to use technology again to sort of connect with families. As many organizations during this time, and we were one of them, decided that we needed to relook at our visitor policies. So we, for our inpatients, we tried to use technology to make sure that family members that couldn't be at the bedside during this time still were connected, still had the opportunity either telephonically or through the Zoom platform that we use, could connect with the treatment team and the patient. We also tried to focus really on whole person care, which is something that is very important to us here at the Cancer Institute. Some of the ways that we did this, again, is engaging our learners. So those medical students and residents that had to be pulled out of the clinics and hospital training, we tried to connect them to some of our patients that were interested in having those conversations, so that we could again sort of foster some good relationships between our patients and our learners. Again, it's a different type of connection for the medical students. They weren't quite part of the treatment team. They were part of a phone a friend program. But again, we felt that it was important because it not only helped our inpatients, but it also gave the medical students really a different look at what it's like to be a patient. Next slide, please. Another Another program that we have, again, a little bit different and unique, but we have through our Department of Humanities an arts in healthcare program. And this program is deeply engaged in our inpatient and outpatient services. One of the things that our patients have said they really enjoy about the program is having visual artists and musicians perform within our clinic and inpatient areas. Of course, during COVID, we weren't able to do this, but our creative team was able to very quickly turn things around and offer a lot of online content with the same artists and musicians that our patients were used to seeing in the clinic or in the common areas and on the inpatient units. Again, just trying to find opportunities to engage patients, to make sure that we nourish their well-being in any way we could. Next slide, please. So again, wanted to sort of say something briefly about clinical research because it is something that we too are engaged in. We focused on the same type of priorities using the good guidance that was available to us, and then making sure we evaluated the visit schedules according to all of those clinical trials, and really looking at our portfolio of clinical trials. As Dr. Reyes mentioned, we had a similar situation, of course. The number of accruals is likely to be lower when we look back at it. But we did want to try to focus on how important clinical research is and how the therapeutic value to our patients and in moving those forward. Next slide, please. So the new next, we often hear people say the new normal without quite knowing what normal is going to be. One of my colleagues coined this phrase because we don't know what's next, but we're going to be ready for it. Like my other panelist says, we are certainly in the process of ramping up our cancer screening, utilizing pre-procedure testing when necessary, and figuring out how best to use telemedicine. We too have been challenged to find that balance, and our physicians are challenged with figuring out how to utilize it. We have struggled a bit with patients and having access to the technology they need in order to use the platforms. But again, trying to focus on how to best apply it. Really, we've done a number of things. I'm sure all have to try to work on our operational workflow to reduce those touch points and ensure sort of consistently safe care. I think this gives us an opportunity to really focus on those changes that we've made during this time and keeping what's going to work for us as we move forward. And then I think really what I've been most happy about, and it is really celebrating the strength of our community and our employees as we move forward. I think our employees have really done an incredible amount of work to create a safe environment, to communicate our ability to take care of patients. And I think it's bearing fruit. I think that we are seeing with our numbers that our community is starting to feel comfortable. And I think we want to move that forward. I think there really is a leadership opportunity for those in the oncology field. We have always cared for patients that were immunocompromised. We've always focused on on how to keep patients safe. And I think that our field is really in a position to offer both on the research and clinical side, but also on the operational side. We're in a position to offer lots of good experiences that hopefully others will utilize. Thank you.
Shioko, thank you so very much. We truly appreciate your content and information. Laura Toole is our next speaker that will continue the theme from the Northeast Regional Cancer Institute. And Laura, are you available on the line? Can you check and see if you're muted, maybe?
Yes, Laura, you're still showing up as muted. Tiffany, are you there?
I am.
Would you be able to, as the organizer, to try to unmute all?
Let's see. See if I could do that. Give me a second to see if I can figure out how to do that.
Tiffany, if you go to, I just sent you a number, if you could even just try to unmute that one particular phone number, that would be great. Laura, now it looks like you're unmuted. Are you able to speak? Or now you look like you're muted. Our apologies. And thank you guys for all your understanding as we are working through, of course, just a little bit of our own space of normalcy as a coalition. I do know that we are running close to 12 o'clock and we definitely want to be mindful of time, but also to the content that we wanted to provide to you today. So just thinking if you do have the availability to stay on and kind of work through this with us, that would be wonderful. We definitely want to extend that. And of course, to continue any questions that you have for any of our panelists through the chat, we would definitely want to utilize that. And we can always advance those questions to our panelists post-call and circle them back to this group.
So Laura is on via phone?
Yes.
Okay, so Laura, do you have your phone on mute? Because I'm not sure why we aren't
Connecting. Yeah, I agree.
Mm-hmm.
Laura, if you could hear me, can you type into the chat box, please, just so that we know you're hearing us as well and that you're there? I guess maybe if she's on the phone, she can't type into the chat box, come to think of it.
Kate, perhaps we can continue Laura's presentation for the next meeting.
Right.
I think that would be great. Our apologies, of course, in thinking about the perspective of screening, as you heard from even some of our other presenters, that was a component that's really what we're doing now on our minds now as one piece of clinical care. So with thinking about that, we could even spend some time specifically on that, and even from the perspective of just the services that the Northeast Regional Cancer Institute provides in particular.
So at this point, I think we will open up to question and answer. I'm particularly interested, coming from more of a clinically based area that does an enormous amount of cancer screenings, everyone's thoughts on cancer screening, and are you opening up shop to be able to conduct and continue? Or I know we've developed a playbook at Jefferson, but I'd be really interested in that particular aspect.
Yeah, this is Larry, and at Penn, we've gradually started to increase cancer screening, primarily mammography and colonoscopies. Like others have mentioned, I think Vincent may have mentioned this, we have a lot of patients who frankly are declining to come in at this point. And the screening intervals are somewhat arbitrary, and I think delaying a couple of months for somebody who's asymptomatic and a standard risk patient, waiting a few months is not a problem. But what we've all worried about are the patients who are at high risk, or the patients, in fact, who have symptoms. So they're not really screening patients, but they've yet to be diagnosed. Their primary care offices are closed, or they're reluctant to come in for evaluation. And those patients are having delays in their diagnosis and are coming in with more advanced disease. And we've seen that a fair amount over the last couple of months. And we've tried through public awareness messages to urge patients who are not well and are concerned that they may have a problem to come in and be evaluated.
And Dr. Shulman, that's huge. I know at our shop, we've been doing an enormous amount of scripting, telephone scripting, both with our clinical navigators as well as with our phone intake people. But I honestly believe that some of the public messaging has just been incredibly useful because it's not just one group telling you you must, but it's rather a community service that you must. I would also ask, has anyone found for those patients that really do have high anxiety, high concern, worried about not being able to have family members in with them during their appointments, have you found anything that's been particularly successful?
You know what we found, Peg, was that there was a lot of concern with not having the support person with the patient, and so we actually relaxed our restrictions. At first, it was just the patient and nobody else. In very rare instances do we allow a support person, but now we actually are welcoming support persons back in because of exactly what you said. That is another avenue to try to get patients back in, because it's not just the patient who actually is worried, the family is. And if the family says, Grandma, you're not going in, or Mom, you're not going in. But if you invite them into your clinic and actually explain, hey, look, these are the things that we're doing, and they actually see it for themselves, how safe it is in the various clinics and all the various temperature screening, everything else, that makes a world of a difference.
Yeah, this is Larry. I would just add that rightly or wrongly, and I'm not sure that it's scientifically correct, patients have been more comfortable going to our regional sites than coming to downtown Philadelphia. Even before we had problems with civil unrest and road closures and things like that, which fortunately is getting better. But this has been a trend across the country, and we've gotten feedback from a lot of our fellow cancer programs around the U.S. that there's a greater demand at the regional sites and a decreased demand at the downtown sites. People are just more comfortable with that. And I know the others on this call in fact, also represents systems with downtown and regional sites as well. Be interested in their thoughts.
Dr. Shulman, this is Pat Halpin-Murphy asking a question about how would you respond to someone who's a cancer survivor in a way that a layperson could understand it. If you're a survivor, not necessarily in active treatment, and they say, am I at increased risk for COVID? Because I've been a cancer survivor, I've had surgery, I've had radiation, I've had chemotherapy, I may have had hormonal treatment, or whatever the additional treatments might be.
Yeah, so that's a great question. And as I mentioned, I think the data is relatively weak, but what data that we do have is concerning. I also think not all cancer survivors are the same. Largely what I do is cancer survivorship. I have a very large cohort of patients who are cancer survivors, and the data would suggest that patients who were previously treated for lymphoma, for instance, with both radiation and chemotherapy, have lifelong immunosuppression. And I think those patients are particularly at risk. And for those patients in my practice, I've advised them to be extra cautious and watch, where they go and what their interactions are. It may be less for patients who have breast cancer and have just received hormonal therapy, but we don't really know that either. So we've told all of our cancer survivors to be very cautious, to consider themselves at increased risk for poor outcomes if they were to become COVID infected. And I think that's the cautious and wise thing to do.
That's very helpful. Thank you.
This is Kate. Laura, are you able to come off?
Are you able to hear me?
I can hear you. Yes.
Oh,
fantastic!
Lovely.
Thank you. So if it's okay, if we could then switch back to Laura put together some really great information. We'd like to still include that as part of this panel discussion. If we could do that, I understand we are past 12 if folks need to hop off, but would like to, of course, still extend that. Sound okay?
Sure.
Okay, great. Thank you, Laura. I'm going to turn it over to you.
Sounds good. My slide, at least on the screen, disappeared. But so thank you again for inviting the Northeast Regional Cancer Institute to participate. So today I'm just going to give a brief overview of the organization, who we are and what we do, the impact that COVID has had on a regional nonprofit as opposed to a health system, and then talk about what we anticipate moving forward. So staying on this particular slide, we're a Northeastern PA-based nonprofit organization. We're not a treatment facility. We're in our 29th year. We cover the northeast corner of the state of Pennsylvania in terms of our service area. Our mission is to ease the burden of cancer in northeastern Pennsylvania, and we achieve this through three main program areas. We have a cancer surveillance program that, among other things, produces an annual snapshot of what cancer incidence, distribution, and mortality looks like in northeastern Pennsylvania. So we look at the 23 most common types of cancer on an annual basis. And that report for 2019 is being finalized. And every year you can find that, as well as past reports, on our website. We have a regional cancer registry that collects and reports cancer data to the state, and we have community and patient services, and that's the department that I supervise and work with. So next slide, just to give you an idea on the next slide of what services we offer under that. Again, as a nonprofit, not treatment, we focus on community-based education and outreach, and those programs are historically have been done in person, focus on the importance of cancer screening, always with the caveat to talk with your healthcare provider, because we are not one, about what type of cancer screening is appropriate for you, at what age you should begin, and the frequency of that. We also have a cancer screening, community-based cancer screening navigation program that I'm going to speak about in a moment. We offer cancer support services to people either currently affected by cancer or with the history of cancer, and that's through programs and services and special events. We offer healthcare professional education, and we also serve our community as an information and referral resource. So in any given year, we may connect patients, caregivers, healthcare professionals with between 400 and 500 cancer-related resources. And as part of that, we do offer a community-based genetic predisposition education and referral. So for those healthcare practices in our region that don't have anyone on staff trained to do a cancer risk assessment and to help facilitate genetic testing, our job is to accept those referrals and then connect them to appropriate cancer genetics professionals. And in any given year, we facilitate between 30 and 40 of those referrals. And then next slide, I'm going to briefly describe our community-based navigation program, because in the past decade or so, this has largely been our focus. So what is this? It's a barrier reduction focused telephone intervention and our goal is to help facilitate the completion of breast, cervical, colon, and or lung cancer screenings for low-income individuals and residents in northeastern Pennsylvania who are not current with those screenings. The majority of our patient population referral base comes from our partner healthcare organizations, and these are free and sliding fee scale clinics, so F2HC and F2HC-like entities. And through business associate agreements, we have taken care of the HIPAA issue. So we probably, with all of our providers in the region, have at any given point working with about 10,000 of their patients from all of those sites combined. As I mentioned, our target population is low income and underinsured. And importantly, although we work very closely with the statewide breast and cervical cancer screening and treatment program, we can be the payer of last resort for screening and diagnostic workup for either, if we're talking breast and cervical, for those women who may not qualify for that service, but then importantly for things like colon and lung, where there are no statewide screening program funds, we can be, again, the payer of last resort to cover that diagnostic piece. And again, finally, since the program's inception in 2012, we've been able to facilitate the completion of over 6,000 cancer screening, and that's for all sites. And then next slide, just want to give you a snapshot of what COVID looks like in northeastern Pennsylvania. We were a hot spot, so to speak. So I won't go through all of the counties, but as of this data is from last Thursday. That's when I submitted my slides. So we are approaching 7,000 cases at this point, with over 500 deaths as of today. Many of those deaths have been in nursing homes. And then you can see by county the breakdown in our more populous counties like Luzerne, Lackawanna, and Monroe. We've seen more cases. And we were one of the last regions in the state to go yellow, and that happened last week. And then next slide, just to talk about, you know, as a small regional nonprofit, what is the impact of COVID on services? You know, initially there were some logistical issues. Again, we're a small organization with finite resources. We had, as many non-essential businesses or organizations, nonprofits, we had a single day's notice of office closure. And although some of our staff, particularly the registrars, were set up to work remotely, that was not the case for any or for most of the community and patient services staff. I'm happy to say that we were able to, with our IT consultant and staff, who it was sort of a team effort, we were able to do that impressively quickly, if I do say so myself. And then just in terms of the programmatic issues that we're looking at in terms of COVID and moving forward, community outreach, we had all of our spring program events have been postponed through the early fall, and we're exploring in conjunction with other partner cancer organizations what those best practices might look like, alternative methods to conduct that kind of outreach. Our cancer screening navigation program, as I said, it's a telephone intervention, so it does lend itself to what's going on regionally. Of course, we've been in ongoing communication with those healthcare partners that I referenced and our screening facilities. Initially, many of our screening facilities were only seeing symptomatic or diagnosed patients, but they are now reopened. So part of what we're doing in terms of messaging is that we have revised our scripts to talk about COVID precautions, the importance of making sure that each individual patient talk to their healthcare provider to balance that sort of the benefit of cancer screening versus any comorbidity that patient may have. And then also educating patients about the awareness of protocols at screening sites, how that's going to work. And then importantly, recognizing that people have a lot of non-cancer screening related concerns that might prevent them from seeking screening, is that we are able to talk to them about non-cancer related COVID resources. So whether that's housing, whether that's health insurance if they've lost it, shelter, food, if you will, and so on. So my last slide, it's becoming an overused phrase, I know, but in terms of moving forward, organizationally, as all of the other panelists have referenced, this is an evolving situation, so there's a tremendous amount of uncertainty. But however, I will say as a small organization, and we've always been able to do this, I think that's partly why we've been here for 29 years, we are sort of uniquely positioned that we can we can look at the landscape of what's going on in the northeast part of the state and cancer needs and be pretty nimble and flexible in responding to rapidly changing circumstances. We have a long history of doing that, and I think that's going to be one of our strengths. We've been around for a long time. We are a trusted source within the region. We have strong, lengthy partnerships with our regional health systems, our regional insurers, other cancer-related nonprofits in the community. And just to finish, in terms of programmatic, we are anticipating, changing our outreach model, and we're in close collaboration and communication with other nonprofits in terms of what that will be. But we do think some of the virtual programs that we've begun to offer may expand our outreach, so that may be a positive. As I said, we're adding COVID-related concerns to assessment and resource offerings with the people who contact us, whether that's through the navigation program or through information and referral calls. We do anticipate, unfortunately, with the loss of jobs, that a tremendous amount of individuals may have lost their health insurance or will be, so that the need for this type of programming will become even more important. And lastly, our organization and this program in particular is largely funded by grants, by state funds, for which we're very grateful for, and for community fundraising. And in the age of COVID, that's always been a competitive area, and we anticipate that it will increase. However, as I said, we do think that based on some of the information presented by the other panelists, that the need is going to be great for this type of programming, and we intend to use, that data to help make a case for ongoing support for our program. So my apologies for patients related to the technical issues, and I appreciate your time and attention and the opportunity to present on what we offer.
Thank you, Laura, for holding on for us to work through those issues. Let us extend that gratitude to you. Peg, I'm going to turn it back over to you for any final words for the panel.
Yeah, what I would ask each of you is, if you were able to do one thing for your patients as you move forward post-COVID, give me a one sentence on what you think your patients would want and what you would want for them.
This is Larry. Sure. Well, I'm not good at one sentence anythings. But I think our patients want to be able to continue safe and effective care that's delivered in a way that, in fact, does keep them safe, but doesn't deny them life-saving and life-prolonging therapies, the best that we can offer them. So that's my sort of one run-on sentence, if you will.
Perfect. Thank you. Dr. Reyes?
You may have had to jump. Mm-hmm.
Yeah, certainly. Shioko?
Yeah, I guess I would say I hope that our patients feel comfortable continuing a dialogue with us. I think that having good communication is really key, and making sure that we can maintain those connections however possible is really going to be important. I think that I'll put a shameless plug in for our nurses. Our nurse coordinator group has really been what the sort of glue that has kept everything together. They have deep relationships with their patients. Those that are in active treatment and those who only come in yearly. And I think that we've been trying to find time for those staff members to have the opportunity to make those connections and stay connected to those patients, because I think it's that personal connection that makes people feel confident in their care and builds that trust. And so I hope that everybody has an opportunity to feel that kind of confidence in their caregivers and moving forward.
Yeah, I would have to agree with you on that one. Laura, last comment?
Yes, I would just say what we're hearing from a lot of our patients and caregivers is and they recognize the importance of limiting the number of people that are able to support through treatment and assessment and consultation, but figuring out a way to make sure that that identified family members and caregivers will be able to provide the on-site support as patients are sort of navigating cancer care. I think sometimes that can be critical. So that would be something that we're hearing from patients.
Sure. So with that, I just wanted to make sure that I thank everyone for their extraordinary expertise and time. I think trust is coming out as the big factor. I think safety and security most certainly, but we don't want that to miss the opportunity for innovation. And I think you all have done innovative work during a crisis, which is pretty remarkable. So thank you very, very much. And to all, please note that this has been audio taped, videotaped, and hopefully you'll be able to share with your colleagues. Appreciate the expertise.
Absolutely. And to just echo that and in some closing remarks, exactly what Peg had reiterated, that this is a recorded call. We want to make sure that we can circle back to that content as we continue to move forward ahead. We thank everyone for their time, of course, to our speakers for lending your time to this group and really advancing the dialogue. We cannot thank you enough. And even learning a little bit about how we as a coalition are meeting. Thank you for working with us on that too. Really just want to extend the gratitude from all of us to all of you. And Mark, I don't know if you're still on, if there's anything you'd also like to add to that in closing.
Hey, Kate, I am here. Thanks for giving me a moment. So I think that the panel was fantastic. What a tremendous amount of knowledge and information shared. And time and time again, I was shaking my head in agreement with the reactions and the approaches that you all have taken, and we've taken similar approaches. So it's really confirmed that we've all really tried to do our best, and we're really relying on these shared practices and kind of confirming that we've done the best that we can to protect our patients and be responsive, but it also helps us kind of how we formulate our response going forward. So the panel has really been terrific, and I think today's forum is a success, and it would only get better from here, and it was great to connect with everybody today.
Absolutely. So if there's any questions that anybody has to any of our speakers, you can still log that into the chat or reach out to us after. We will make sure to extend those questions to our experts to make sure that we're also following up on that and giving that good content. So with that, I thank everyone once again, and we'll call this meeting a close. Enjoy the rest of your day. Thank you for staying on just a couple of extra moments, and really look forward to the road ahead of us in the state of Pennsylvania. Thank you.
Okay. Thank you very much for including us.
Thanks, everyone. Take care.
Thank you.
Thank you.